Bismillahirrahmanirrahim. The next topic of our discussion is vasculitis. So, vasculitis refers to inflammation of the blood vessels, irrespective of their size and location. The vasculitis could be either due to any infectious cause, such as phlebitis, or it could be non-infectious, which is also known as immune-mediated vasculitis. The risk factors for immune-mediated vasculitis include certain drug allergies, such as penicillin, and infections like hepatitis B virus infection, which is present in almost 30% cases of polyarthritis nodosa. Smoking and genetic predisposition also are the predisposing factors to vasculitis. So vasculitis is actually a very broad term and includes many types of vasculitis. The most common classification that is used is known as Chapel-Hill classification. The Chapel-Hill classification divides the various types of vasculitis into three main subcategories. The first is the large vessel disease, the second is the medium vessel disease, and third is the small vessel disease. Giant cell arteritis and Takayasu arteritis are included in large vessel vasculitis, whereas the polyarthritis nodosa and Kawasaki disease are included in medium vessels vasculitis, since they affect the medium-sized blood vessels. The small vessel vasculitis affects mostly the arterioles and venules, along with the capillary bed, and they include vaginal granulomatosis, Churg-Strauss syndrome, and microscopic polyangiitis. We will discuss each of these diseases separately in the next lectures. The pathogenesis of vasculitis involves three main mechanisms. The first is the immune complex mediated vasculitis. The second is anti-neutrophilic cytoplasmic antibodies or ANCA associated vasculitis. And the third is anti-endothelial antibodies mediated vasculitis. So the immune complex mediated vasculitis is actually type 3 hypersensitivity reaction in which certain antigens such as the drug haptens or antigens produced by the viral infections like hepatitis B virus act as the antigens. Haptens are actually the drug particles that do not act as an antigen alone, but when they combine with the proteins in the body, they start acting as an antigen. A common example of drug hapten is penicillin. So these antigens are recognized by the antibodies, hence forming the antigen-antibody complexes, which deposit in the blood vessels, causing vascular inflammation or vasculitis. In certain cases of immune complex mediated vasculitis, antigens remain unidentified. And moreover, it is also unclear that the antigen-antibody complexes are either formed in situ, which means either they are formed in the vessel bed or they are formed elsewhere in the body and then deposited in the blood vessels. The examples of immune complex mediated vasculitis include polyarthritis nodosa, systemic lupus erythematosus, and serum sickness syndrome. The second mechanism of the pathogenesis in vasculitis is ANCA-mediated disease. First of all, there is an inciting incident, such as an infection or exposure to a certain toxic, and in response, the neutrophils and certain other cells like endothelial cells express proteinase 3 and myeloperoxidase enzyme on the cell surface. The ANCA antibodies are formed against inciting agent, but in predisposed individuals, these ANCA also identify proteinase 3 and myeloperoxidase as an antigen. Proteinase 3 is actually a lysosomal enzyme and it acts as an antigen in microscopic polyangiitis and Churg-Strauss syndrome. Whereas myeloperoxidase is a neutrophilic enzyme and it acts as an antigen in vaginal granulomatosis. So the ANCA antibodies form antigen-antibody complexes with proteinase 3 and myeloperoxidase, and they cause direct injury to the endothelium, and moreover, it also results in the degranulation of the neutrophils. The degranulated neutrophils release reactive oxygen species and certain cytokines, resulting in vascular inflammation causing vasculitis. So ANCA are actually autoantibodies which are formed against the neutrophilic granules, monocytes, lysosomes, and also endothelial cells due to resemblance in the surface proteins. The levels of ANCA in vasculitis patient directly predicts the degree of vasculitis, and it is also helpful in the management of the disease. The third mechanism is formation of anti-endothelial antibodies, which are formed against the certain surface proteins present on the endothelium. So the antibodies form antigen-antibody complex and cause damage to the blood vessels, resulting in vasculitis. The examples of this mechanism include Kawasaki disease and Takayasu arthritis. The signs and symptoms of vasculitis present as the combination of systemic effects as well as the local effects. The local effects include rash and localized ischemia. Moreover, the local effects also depend upon the type of vasculitis and the blood vessel affected by the disease. The systemic effects include fever, weight loss, and fatigue. A suspicion of vasculitis should be raised in the patients presenting with the multisystemic involvement. There is an increase in the inflammatory markers present in the blood, such as CRP and often erythrocyte sedimentation rate. Anti-nuclear antibodies are often detectable in the serum. So this concludes our generalized discussion about vasculitis. We will discuss each type of vasculitis in the next lectures. So far, if you have any questions, let us know in the comment section. Thank you.